Welcome to the deep dive. We're here to take a whole load of complex information and basically boil it down to what you really need to know.
Giving you that shortcut to getting well-informed quickly.
Exactly. And today, we are zeroing in on fibromyalgia. This is all geared towards efficient revision.
Yep, we've gone through some pretty comprehensive revision notes.
And our mission, really, is to give you a clear, high-yield understanding. We'll cover all the key bits without hopefully making your head spin.
We know revision can feel, well, a bit much sometimes.
Like a marathon, yeah. But think of this as more of a focused sprint through fibromyalgia.
Precisely. Fibromyalgia, it's got a lot of facets, hasn't it? So for revision, you really need to grasp the core ideas and how they all link up.
Okay, let's dive in. Let's unpack this. Fundamentally, what is fibromyalgia?
Okay, so at its core, it's a chronic disorder. Think widespread musculoskeletal pain, that's pain pretty much all over, plus significant fatigue and tenderness.
Right, pain, fatigue, tenderness. But you said it's multifaceted.
It is. It's really important to remember it's not just about the pain and tiredness, common as they are. There's often a whole cluster of other things going on.
Such as? Give us the full picture.
Well, sleep disturbances are really common. People often, struggle to get to sleep, or they wake up a lot, or just don't feel refreshed even after sleeping.
Okay.
Then you've got cognitive issues. People often call it fibro fog.
Ah, yes, the fog. Heard of that, like concentration problems?
Exactly. Memory difficulties, trouble concentrating, and also mood disorders. Things like anxiety and depression are very frequently part of the picture.
Understood. So it's way more than just aches and pains. How can we sort of lock that in for revision? Any quick memory tips?
You could try thinking wide fatigue and tender minds.
Wide fatigue and tender minds. Okay, break that down.
Sure, wide for the widespread pain. Fatigue, well, that's obvious. Tender for the tenderness points or areas. And minds covers those cognitive bits, the fog and the mood aspects like anxiety and depression.
Wide fatigue and tender minds. Got it. Excellent. Okay, so that's what it is. Now, where does it come from? The etiology. This is where it gets really interesting, right?
It really is. And this is absolutely crucial for revision.
Right.
The exact cause of fibromyalgia. We don't know.
Right. No single smoking gun.
Nope. It's not down to just one thing you can point to. The general thinking now is that it's multifactorial.
Multifactorial, meaning?
Meaning it probably comes from a combination of things. Your genetic predisposition plays a part.
Okay, so family history might matter.
Yeah. Then there are environmental factors, things you're exposed to. And also psychological factors seem to contribute. It's a complex interplay.
Complex indeed. Are there specific things that might sort of kick it off? Triggers?
Well, while they aren't the underlying cause, certain things do seem to act as potential triggers in people who are susceptible.
Like what?
Things like physical trauma, a car accident, maybe a significant injury, or emotional trauma can be a factor too. Infections have also been linked in some cases. And interestingly, already having another rheumatic disease, like rheumatoid arthritis, for instance, can sometimes precede the onset of fibromyalgia.
That's useful context when thinking about a patient's history. So leads nicely into risk factors. Who's more likely to develop this?
Good question. Several factors increase the risk. Firstly, as we just touched on, family history. If it runs in the family, your risk is higher.
Makes sense, the genetic link.
Secondly, having those other rheumatic diseases like RA or lupus, SLE, that bumps up the risk.
Right.
Thirdly, and this is quite a big one, gender. Fibromyalgia is significantly more common in women than in men.
Okay, noticeably so.
Oh yes, quite a bit more common. And finally, that history of physical or emotional trauma we mentioned earlier is also a recognized risk factor.
Okay, so family history, other rheumatic conditions, being female, and past trauma. Got it. Now let's get a bit more into the biology, the pathophysiology. What's actually going on inside the body?
Right. The key concept here, the thing to really grasp, is abnormal pain processing. It seems to happen within the central nervous system, the brain and spinal cord.
So it's not primarily about damage out in the muscles or joints themselves?
Generally, no. It's more about how the central nervous system is interpreting and managing pain signals. It's like the volume control for pain is faulty.
Faulty volume control, like that analogy.
Yeah, and linked to that, we see an altered balance of neurotransmitters. Those are the chemical messengers in the brain. Specifically, changes in levels of serotonin and dopamine seem pretty important.
And those changes contribute to the widespread pain.
That's the thinking, yes. They play a big role in how pain is perceived and modulated, so imbalances can lead to that heightened, widespread pain experience.
Fascinating. So the body's pain interpretation system is kind of out of whack. Now, if someone comes in with these symptoms, widespread pain, fatigue, what else could it be? What are the key differential diagnoses we need to keep in mind for revision?
Absolutely crucial to think about this. You need to rule out other conditions. Top of the list, perhaps, is chronic fatigue syndrome, or MECFS. Big overlap with the fatigue, obviously.
Right, makes sense. What else?
Hypothyroidism. An underactive thyroid can cause fatigue, muscle aches, feeling cold. Lots of overlapping symptoms.
Okay, thyroid check is important then.
Definitely. Then there's polymyalgia rheumatica, especially in older adults, presents with pain and stiffness, particularly in the shoulders and hips.
Got it, PMR.
Also, you'd consider inflammatory myopathies, muscle diseases like polymyositis or dermatomyositis, and sometimes metabolic myopathies too.
So conditions directly affecting the muscles themselves.
Exactly. Ruling those out is part of the process.
Okay, that's a good list of differentials. What about conditions that often seem to sort of travel with fibromyalgia, associated conditions, the bigger picture?
Yes, that's another key aspect.
Yeah.
Fibromyalgia rarely travels alone, so to speak. It often coexists with other conditions.
Like what kind of things?
Well, mental health conditions are very common. Associations, generalized anxiety disorder, depression, very frequent.
Okay.
Then you often see irritable bowel syndrome, IBS, lots of gut issues, and similarly, irritable bladder symptoms can occur.
Right, gut and bladder.
In women, you might see dysmenorrhea, painful periods, and PMS being more severe. Restless leg syndrome is another common one.
Restless legs.
Also, things like non-cardiac chest pain, temporomandibular joint pain, TMJ, or jaw pain, Raynaud's phenomenon.
Raynaud's, where fingers go white and cold.
That's the one. And Sika syndrome, which basically means dry eyes and dry mouth.
Wow, okay. That is quite a collection of associated conditions.
Yeah.
And didn't you mention earlier something about overlap with other rheumatic diseases specifically?
Yes, and this is a really significant point. There's a major overlap. Estimates suggest around 25%, maybe 1 in 4, patients with rheumatoid arthritis also have fibromyalgia.
1 in 4.
And for SLE or lupus, it could be as high as 50%. Half of lupus patients might also meet criteria for fibromyalgia.
That's huge. Really underscores how these things can cluster together.
Absolutely. It complicates the picture, but it's vital to be aware of.
Okay, definitely. Let's talk numbers then. Epidemiology.
Yeah.
How common is this, particularly here in the UK?
Right. So in the UK, current estimates put the prevalence somewhere between 2% and 4% of the population.
2 to 4%.
Mm.
That's actually quite a lot of people.
It is.
Yeah.
And remember that point about gender, it's much more common in women.
Right.
While it can technically affect anyone at any age, it's most typically diagnosed in middle-aged individuals. Globally, the estimates are pretty similar, maybe around 2 to 3%.
And the gender difference holds globally, too.
Oh, yes. Women are thought to be affected maybe up to 10 times more often than men. It's a really striking difference.
10 times, okay. And age range again.
Typical onset is often between 20 and 50 years old. But again, stress that it can affect children, adolescents, and older adults too.
Got it. Any links to socioeconomic factors?
Some studies suggest links with lower levels of education and income, and as we've said, having other rheumatic diseases is also associated with a higher prevalence. But it really can affect anyone.
Okay, so widespread, more common in women, often middle-aged, but not exclusively.
Right. So we've covered a lot of ground definition, causes, risks, biology, differentials, associations, numbers. Let's get practical. What does it actually look like? What might you see and hear from a patient? The clinical presentation.
Okay, the absolute key symptom, the one that's pretty much always there, is that widespread musculoskeletal pain.
Widespread, meaning?
Meaning pain in multiple parts of the body, often described as being above and below the waist, and on both sides of the body.
Right.
And crucially, it has to have been going on for at least 3 months.
3 months minimum.
Right.
And what else comes with that pain?
Alongside the pain, you'll almost always hear about significant fatigue. Not just tiredness, but often profound exhaustion. Sleep problems, as we mentioned, difficulty sleeping, waking up feeling unrefreshed.
The non-restorative sleep. Exactly. And that fibro fog, cognitive difficulties. Headaches are also common, symptoms that sound like IBS. And often signs or symptoms of depression and anxiety, it's a real constellation of symptoms.
A constellation. Yeah,
Yeah.
that sounds right. So how do you actually pin down the diagnosis? You said there's no single test.
Correct. Diagnosis is primarily clinical. It relies heavily on the patient's history, listening carefully to their story, and a thorough physical examination.
So no blood test says, yes, it's fibromyalgia.
No, definitely not. The tests we do are mainly to rule out other things. On examination, you might find specific tender points areas that are painful when pressed, although the official diagnostic criteria have moved away from relying solely on counting these points.
Okay. That's changed a bit then.
Yeah, the focus is broader now. But
Okay.
importantly, on exam, you typically don't find objective signs of inflammation like swollen joints. That helps distinguish it from conditions like rheumatoid arthritis.
Right. Absence of joint swelling is a key feature. So, thinking about the history again, what specific clues would point you more towards fibromyalgia, especially when you're weighing it against those differentials like RA or lupus?
Key things in the history would be that description of pain in multiple places, the persistent, often quite disabling fatigue, the sleep issues we talked about, maybe some morning stiffness, though it might not be as prolonged as in inflammatory arthritis. Those cognitive complaints, the fog, frequent headaches, and often a history or current symptoms of anxiety or depression.
Okay. Anything else they might mention?
Patients often report that their symptoms get worse or flare up with certain things. Cold or damp, humid weather is a common one. And periods of increased stress, physical or emotional, often exacerbate symptoms too.
Right. Sensitivity to weather and stress.
Right.
Understood. Okay, so diagnosis is clinical pattern recognition, ruling out mimics. You mentioned investigations are mainly for ruling things out. What sort of tests are we talking about?
Precisely. It's about exclusion. So you'd typically do some routine blood tests, a full blood count, FBC or CBC, ESR, erythrocyte sedimentation rate, and CRP, C-reactive protein.
And what are those looking for?
They help look for signs of inflammation or other systemic illness. In fibromyalgia, these inflammatory markers like ESR and CRP are typically normal.
Okay, normal inflammation markers. Good clue. What else?
Thyroid function tests are usually done to rule out hypothyroidism. Depending on the clinical picture, you might consider tests for rheumatic diseases like rheumatoid factor or ANA, anti-nuclear antibody, if there's suspicion of an autoimmune condition like RA or SLE.
Right, checking for those mimics. What about investigating the other common symptoms, like the sleep problems or the fog?
Well, if sleep disturbance is really prominent and severe, a polysonogram, a formal sleep study, might be considered to look for specific sleep disorders like sleep apnea. For the fibrofog, there isn't a specific test. But if mood symptoms like depression or anxiety are significant, a psychiatric evaluation can be really helpful, both for diagnosis and management of those co-occurring conditions.
Makes sense. Any other specialist investigations sometimes used?
Occasionally, if there are features suggesting autonomic dysfunction like big swings in blood pressure or heart rate with posture changes, autonomic nervous system testing might be done, but that's less common.
Gotcha. And you mentioned the diagnostic criteria have evolved beyond just tender points. Can you summarize the current approach for revision?
Yeah, the current criteria, like the 2016 ACR criteria, use two main components. The Widespread Pain Index, WPI, which counts the number of areas where the patient has had pain.
Okay, a pain map, basically.
Sort of, yeah.
Right.
And the Symptom Severity SS scale. This scores the severity of fatigue, unrefreshed sleep, and cognitive symptoms, plus the extent of other general physical symptoms. So generally, the diagnosis requires a certain score on both the WPI and SS scale, for example, WPI of 7 or a WPI between 3 and 6, plus an SS score of 9 or more.
Okay. Specific scoring thresholds.
Yes. Plus, the symptoms need to have been present at a similar level for at least 3 months. And crucially, the diagnosis assumes that the symptoms are not fully explained by another disorder.
Right, the exclusion part again.
Exactly. The emphasis is really on that clinical assessment, careful history, and ruling out other conditions, not over-investigating. Though it's worth noting there's growing research looking into things like small fiber neuropathy or peripheral nerve dysfunction in some fibromyalgia patients, so maybe electrodiagnostic studies might play more of a role in future, but not routinely now.
Interesting development to watch.
And tools like the Fibromyalgia Impact Questionnaire, FIQ, can be useful too, not for diagnosis, but for assessing how much the condition is affecting someone's function in daily life. And always, always a thorough personal, family, social, and psychological history is just paramount.
Yeah, really comprehensive assessment needed. So once the diagnosis is made or strongly suspected, let's talk management. What can actually be done to help people with fibromyalgia?
Management is key. And it absolutely has to be multidisciplinary. There's no single magic bullet. It's about combining different approaches, therapies, lifestyle changes, sometimes medication.
Okay, let's break that down. What about pharmacological management medications? When do they come into play?
Medications are generally considered for people with moderate to severe symptoms, especially if non-drug approaches haven't been enough on their own. They're not usually the very first thing you reach for.
Right. And what types of medications are used?
Often the first line considered are certain types of antidepressants, but used at lower doses than for depression, primarily targeting pain and sleep. Tricyclic antidepressants like amitriptyline are a common starting point.
Amitriptyline. Okay. How does that work?
It seems to help modulate pain signals and improve sleep quality. You typically start with a very low dose, like 10 milligrams at night, and gradually increase it if needed and tolerated, maybe up to 75 milligrams.
Low dose, taken at night.
Okay.
Got it. Anything else used early on?
Sometimes muscle relaxants like cyclobenzaprine might be added if muscle spasm or tightness is a big issue, but again, often short-term use.
Okay. And what if those first-line options don't cut it? What's next?
If the response isn't great, you move to second-line options. SNRIs, serotonin norepinephrine reuptake inhibitors like duloxetine or venlafaxine might be considered.
SNRIs, also antidepressants.
Yes, but they work on both serotonin and norepinephrine, and they have evidence for helping with pain and fatigue, particularly if depression is also present.
Okay. Any other class?
The other main group are the alpha-2 delta ligands, which are technically anticonvulsants, drugs like pregabalin and gabapentin.
Pregabalin and gabapentin.
Oh, wow.
What do they target?
They can be particularly helpful for nerve-related pain aspects and sometimes for severe sleep disturbances.
Right. And can these be combined?
Yes, in some cases, if someone isn't responding well to a single medication, combination therapy using drugs from different classes might be tried, but always carefully weighing risks and benefits.
Okay, so there are medication options, but you stressed that the non-pharmacological side is crucial. What does that involve?
Absolutely vital, often the foundation of management. First off, patient education and counseling. Helping people understand the condition, what it is, what it isn't, is so important. It empowers them.
Empowering people.
Yeah.
Yeah, that makes sense.
Then exercise. Regular graded exercise is one of the most evidence-based treatments. Both aerobic exercise like walking, swimming, cycling, and strength training.
Graded exercise, meaning
Yeah.
Start low, go slow.
Exactly. Tailored to the individual's ability, building up gradually, consistency is key.
Okay. What else non-pharma?
Cognitive behavioral therapy, or CBT. This helps people develop strategies to manage pain, challenge unhelpful thoughts about their condition, improve coping skills, and address associated mood issues.
CBT sounds really important for the psychological aspects.
It really is. Other things that can help include relaxation techniques, maybe mindfulness. Specific rehabilitation programs or physiotherapy can help with function and movement.
Physiotherapy for specific exercises.
Yes, and guidance on pacing activities, managing flare-ups. Some people also find acupuncture helpful for pain and stiffness relief, though the evidence is a bit more mixed there.
Okay, so education, exercise, CBT, physio, relaxation. A real toolkit approach.
That's exactly it. It's about finding the right combination from the toolkit for each individual and always assessing their pain and function within their whole life context. Psychosocial factors are huge. Treatment needs to be tailored.
Tailored treatment. Got it. Now, what about official guidelines? What do the NICE guidelines here in the UK emphasize for fibromyalgia management? Key points for revision.
Okay, nice guidelines. They really push for starting with self-management support and those non-pharmacological approaches we just discussed. Education, exercise programs, CBT if appropriate.
So, non-drug first.
Generally, yes. The aim is very much about improving function, quality of life, and helping people change their relationship with pain, their pain behaviors.
Right. And what do they say about medications?
They emphasize minimizing the use of opioids. Big caution there due to risks and lack of long-term benefit in fibromyalgia. They do mention considering antidepressants like amitriptyline or an SNRI for managing pain, particularly if sleep is poor or there's coexisting depression.
Okay, consider antidepressants, minimize opioids, any drugs they specifically advise against.
Yes, they generally advise against using most other antiepileptics, apart from pregabalin or gabapentin in specific circumstances. They also recommend avoiding antipsychotics and benzodiazepines for fibromyalgia pain.
And corticosteroids, like prednisone.
Definitely not recommended. NICE's clear there's no evidence they help in fibromyalgia, and they carry significant side effects.
No steroids. Got it. Anything else mentioned?
They briefly mention coenzyme Q10 as something some people try, but don't make a strong recommendation. The guidelines also really stress the importance of safe prescribing, especially with drugs that can cause dependence.
Ah, the dependence issue.
Yes, discussing risks and benefits, documenting everything, and having clear plans for withdrawal if needed, usually very gradual tapering based on dose and how long someone's been taking it.
Okay, that's a really helpful summary of the NICE approach. Now, looking long-term, what's the prognosis? What can people expect?
It's really important to be honest here. Fibromyalgia is typically a chronic condition. That means it tends to persist long-term, often for years.
So it doesn't just go away on its own usually?
Not usually, no. The course can vary a lot, though. Some people have symptoms that fluctuate quite a bit: better periods, worse periods, or flare-ups. Others might have symptoms that are more constant and stable over time.
Okay, variable course. Is there a cure?
Currently, no. There isn't a cure for fibromyalgia itself, but, and this is the crucial message, effective management is possible. The goal is managing the symptoms effectively and significantly improving quality of life. That is definitely achievable for many people.
So, chronic, variable, no cure yet, but management can make a big difference. That's the key message.
Exactly. Focus on function and quality of life.
Right. What about potential complications? If it's a long-term thing, what are the potential knock-on effects on someone's life?
Well, the main complication really is the impact on quality of life. It can be significantly impaired. People often face real difficulties with daily activities, work, social life.
Yeah, I can imagine the fatigue and pain would make things tough.
Absolutely. It can lead to both physical limitations and emotional distress. Reduced productivity is common, sometimes leading to work disability, and it often results in increased healthcare utilization, more doctor visits, tests, treatments.
Higher healthcare costs too, presumably.
Yes. And another important point is the higher risk of developing other conditions alongside it, or perhaps worsening existing ones, particularly depression and anxiety disorders, as we've mentioned, and sometimes other chronic pain conditions can develop too.
So it can be quite disabling and has wider health implications.
It can be, yes, which is why early recognition and effective holistic management are so important.
Definitely. Okay, so to wrap this up for revision purposes, what are the absolute must-know top-line takeaways for fibromyalgia?
All right, key takeaways. Fibromyalgia: chronic widespread musculoskeletal pain, fatigue, tenderness. Remember, it often comes with sleep issues, cognitive fog, and mood problems. Think wide fatigue and tender minds.
Wide fatigue and tender mind. Got it.
Diagnosis is clinical based on history and exam, ruling out other causes. No specific test for fibromyalgia itself. Inflammatory markers are usually normal.
Clinical diagnosis, rule out others. Check.
Management needs a multidisciplinary approach. Focus first on non-drug options: education, graded exercise, CBT. Medications like low-dose amitriptyline, SNRIs, or pregabalin can help for moderate severe symptoms, but minimize opioids and avoid steroids.
Multi-approach, non-drug focus first, specific meds considered.
Right. And finally, it's chronic, no cure yet, but the goal is managing symptoms and improving quality of life, which is achievable.
Excellent summary. Really hits the high points for revision. Okay, before we finish, here's a final thought for you, the listener, to mull over. Considering that really strong link we discussed between the mind and body in fibromyalgia, and the focus on central pain processing, what role might emerging research, maybe looking at things like the gut microbiome or perhaps even neuroinflammation, play in developing future treatments?
Yeah, or maybe even refining lifestyle interventions beyond just general exercise.
Exactly. Or another angle, given how common it is, but also how often it seems to be missed or diagnosis is delayed, what could we do differently, maybe systemically, to improve early identification and get better support to people living with fibromyalgia sooner?
Lots to think about there. Really important questions for the future.
Definitely. Well, that brings us to the end of this deep dive on fibromyalgia. We really hope that's given you a clear, high-yield rundown for your revision needs.
Hope it helps structure your thinking.
And remember, for more fantastic resources to help you ace your exams, do check out PassThemsSRA.com.
And also, freezesra.com for, well, free resources.
Absolutely. Until our next deep dive, keep exploring, keep learning, and good luck with the revision.